Orthopedic Center podcast, where we talk about everything pediatric orthopedics. And today we have a very special guest speaker, which will be my partner, Dr. Strassberg. Dr. Josh Strassberg has expertise in many areas, but one expertise is in hip dysplasia and hip disorders in the child. So before we start with the questioning, Josh, if you don't mind, you just give us a little background of how you've come about to be the expert in hips.
Oh, absolutely. Thanks for having me. So I did my pediatric orthopedic fellowship at Children's Hospital of Philadelphia. And following that, I ended up going up to Children's Hospital Boston, where I ended up doing a fellowship in adults and adolescent hip preservation surgery.
Excellent. So, we big thing that we see in the practice now and that you see is hip dysplasia. Can you first describe what hip dysplasia is before we get into, how you diagnose this and treat it?
Of course. So the hip is a ball and socket joint. The With hip dysplasia is kind of like a grab bag term where it covers a whole bunch of things. Where you can have it where the socket is shallow or acetabular dysplasia. You can have it where it's loose or it's subluxating, or you can have it to the extreme where it's completely dislocated.
Excellent. So when you have hip dysplasia, first, how do you know that you have it? How do you diagnose it? And when does it get diagnosed?
It's not always that easy. The Some patients, have it at birth. And you can tell because you can feel when you're examining them that the hip is moving or coming in and out. Sometimes it's not. If the socket is just shallow where the hip is not moving or it's just moving very subtly, clinically you're not going to be able to feel anything. So we have to go a little bit off of the clinical exam, but we also have to go off of the history if there's any risk factors that kind of bring us to the concern that there might be something, or imaging, which definitively ends up giving us the answer.
So when you say risk factors, what are some of the risk factors that you would have on a history maybe that would suggest that one child is more likely to have hip dysplasia than another?
So there are a number of potential risk factors. One of the big ones is if the baby is breech at some point during the pregnancy. We don't always know at what point or how long it has to be, but patients that are breech where basically the feet are basically facing down as opposed to the head, it puts different stresses on the hip so that there's more of a risk of having some abnormal stresses causing deformity of the hip. Some other things is if there's a family history, either a parent or a sibling who has hip dysplasia, there is a higher risk. Patients where there's twins or triplets, where there's multiple gestations, there's a higher risk. The other one is if they're a large baby, where the uterus is a little bit tighter and it puts abnormal stresses on the hip.
Okay. And so now you have the risk factors history, and you said you can go ahead and do imaging studies. So what type of imaging studies do you do to make the diagnosis? And is there a better time to do the imaging, or you can do it at any time, or is one imaging better than another?
Well, there's really two primary imaging studies that we will get, and it partly depends on how old they are. So babies that are under the age of 6 months, a lot of the pelvis hasn't calcified yet. It's primarily cartilage. So if it's not calcified, it doesn't show up on X-ray. So if you get an X-ray when they're really young, very often you might not be able to see things, or it's very hard to kind of differentiate what's normal and abnormal. So under the age of 6 months, it's kind of standard of care to use an ultrasound, similar to what's being used on the mothers when the baby's in utero. And this can show all the soft tissues. And it actually has a couple of advantages. Similar to X-ray, it can show you what the shape or morphology of the hip is. The one advantage that it has over the X-ray is that it can actually show any laxity or movement in the hip, which you really can't see on an X-ray. So it gives you actually a little bit more information about the patients where we need to pay more attention or potentially end up treating.
Excellent. And so can you also use it not only as diagnosis, but also determine how you're doing with your treatment, or is just you make the diagnosis, you treat, and you're okay?
No, absolutely. When again, similar when they're under 6 months of age, where the ultrasound is the best means of being able to assess the appearance of the hip, whether it's developing properly or whether it's loose. We use that as our standard to determine where they are and how they're responding. And ultimately, if we need to treat them, we're using that as our guide as to where they are in their treatment and how successful they are as far as responding.
Okay, so you've taken the history, you've made the diagnosis and treatment. So clearly you have an abnormal hip. How do you treat to make it so the child has a normal hip? And then we'll talk about prognosis later.
So the main way that we treat the patients, and again, particularly under the age of 6 months, is to use an apparatus or brace that will hold the hips in a certain position that it delivers the ball to the socket so that things can develop properly. Under the age of 6 months, the standard of care for honestly almost the last 100 years has been the Pavlik harness. And it's a harness that basically goes over the torso and around the legs, and what it does is it holds the hips in basically a flex position and kind of out to the side. And when it does this, it actually delivers the ball to the socket and kind of holds it in that place. Because the pelvis is still primarily cartilage, it's much more malleable. So if it's getting the pressure from the ball in there, it actually will allow the hip joint or the socket to actually develop to the shape of the ball and kind of come back into a normal position. It also allows all of the soft tissues to tighten up so that any of that laxity that we feel or see on the ultrasound can resolve.
Excellent. So that's the Pavlik harness. Is it always picked up at birth, or is it ever picked up later on, a hip dysplasia?
No, and as I was saying earlier, it's not always simple cut and dry. There are definitely times where there are more subtle findings that you may not be able to pick up clinically because there's only so much sensitivity that you have in your hands or on exam. So there are some patients where there are concerning findings later on. There are some patients where it's found incidentally. They're getting other studies, X-rays, say for looking at other parts of the body, and sometimes that's accidentally picked up and can kind of lead us down the road for treatment. And there are some patients where they actually aren't completely dysplastic or abnormal when they're born, but over time it starts to progress, and they're not picked up until they're 9 months, a year, even 2 years, where the hip basically shifts out of place and becomes dislocated. And in those circumstances, the parent may notice that they're walking a little bit funny, or that one leg looks a little bit longer, shorter than each other. There may be some asymmetry in the thigh fold. So there are definitely times where it's not picked up right away and gets picked up beyond the 6 month period, where the ultrasound is not really as helpful.
So you said that Pavlik harness was the treatment of choice up until about 6 months or so, or maybe a little bit older. What happens? Can you treat a hip dysplasia when they're older, or you just have to say you missed it and you can't do anything about it?
No, there are definitely ways that you can actually treat it. Some of the other devices that we can use. There's a hip abduction brace, which is again a brace that brings the hips kind of flexed up and out to the side, similar in concept to the Pavlik harness, which can actually again allow the hips to develop normally in a similar fashion to the Pavlik harness, but it's a little bit bigger, bulkier, more structured, so that it can actually manage a bigger, stronger baby. Uh, in patients where they don't respond to that, there are times where we do have to talk to the patients about surgical treatments or other treatments in the operating room to help try and get the hips to develop properly.
Excellent. So let's say, unfortunately, that a child has hip dysplasia. You said it's subtle. It's not picked up. What are the consequences of not picking up hip dysplasia?
The biggest concern if the hip develops abnormally, and if you catch hip dysplasia early and you treat it, you can actually get the hip to normalize that there are really no consequences later on down the road. If it's not picked up and treated, the concern is you start putting abnormal stresses on different parts of the hip, and there's a high risk of going on to develop hip arthritis. And not necessarily when you're in your 60s or 70s, where a hip replacement does very well, but potentially as young as the 20s or 30s, or on rare occasions, even under the age of 20.
So the bottom line, it sounds like you can listen to the history, do physical exam. Most of the time it's picked up and it can be fixed, but sometimes it can slip away. And you don't want that to happen because the kids could develop arthritis. Is that a really good summary?
Correct. The younger that they are when you pick it up, the quicker or more likely they are to respond successfully and not require any more intervention down the road.
Excellent. Well, that was a great summary. Is there anything else you'd like to add about hip dysplasia? Because that seems like from birth to adolescents that we've covered.
No, basically, the best thing is to be cognizant of what the risk factors are, what things to look out for, so that if you do see any of these things, it can be brought to your pediatrician's attention, so that way they can be evaluated properly and get whatever treatment they need.
Excellent. Well, very informative, Dr. Strassberg, as always. Thank you for being our guest today. And I want to thank everybody for listening. And we look forward to having you on our next podcast where we talk about all things pediatric orthopedics. Have a great day. And thanks again, Dr. Strassberg.
Thank you for having me.